Welcome everybody. We're going to get started soon. I just want to say a few words before an official introduction. But I just really like to thank Dr. Temidayo Fadelu for coming to Canada, Kingston, Queens. First time in this part of Canada. Really appreciate you coming. We're really looking forward to your talks here today and at Grand Rounds tomorrow. So on behalf of the Department of Oncology and the Queen's Global Oncology Program, thank you. And now I'm going to let Dr. Fadelu Bagumya come up and do the official introduction as a friend and colleague of Deos.
Thank you, Scott. It's a pleasure to welcome Dayo, a friend of mine for a long time. I met Dayo in 2014 when I was an intern doctor in Rwanda. He was an internist working with us as we had been setting up our cancer center in Rwanda, and he was my first oncology teacher actually back then. Dayo is a medical oncologist. He did his medical school at Yale University, internal medicine at University of Pennsylvania, and medical fellowship at Harvard, and also MPH at Harvard. Has been doing a lot of work in Rwanda since 2013 actually, and also a lot of research work in Haiti. And it's a pleasure to have him here in Canada. Now, the time for me to welcome him. Welcome.
Thanks, Fidel. I think I might need some help here. Right. Oh, thank you.
You're welcome.
Okay. So thank you. Thanks to everyone for attending, and thanks for the invitation to be here. Sometimes I can be technologically challenged. Yes, it's a pleasure to be here. First time in this part of Canada, as you guys said. So this is the topic of what I will be talking about today. So improving breast cancer care in resource-limited settings. Examples from Rwanda and Haiti. So here's a brief outline of the talk. So a quick overview of breast cancer disparities, some contextual data from Haiti and Rwanda, some mediators of poor outcomes in these countries, some examples of some interventions that we have done and things that we're working on, and just some conclusions and future directions. So feel free to interrupt and ask questions. This can be as informal as you want it to be, and we'll also have some time for questions at the end. So here are my disclosures. I do, some of the research I do has some institutional funding from CEPHIAD. So breast cancer, as you all know, is the most common female cancer worldwide, also the most common cause of death for women worldwide. So these statistics from IARC show that about 2.2 million incident cases, and a little bit close to 700,000 deaths worldwide. So the burden of
Moving forward for people at home.
Is that correct?
Yes.
Okay. Okay, thank you. Like I said, I'm technologically challenged. Let's see. Sarah, I'm trying to go back. How do I get this off the screen, the top part over here?
Is that on the right?
Yeah.
I get
Like this. Oh,
yeah.
Oh, thank you. Okay. Perfect. So there's increasing breast cancer burden around the world, but most of this increase in burden, both in incidence and mortality, what I'm showing you here is mortality, is going to be occurring in low-income settings, so like places in Africa and Latin America. So over the next 20 years, there's going to be an expected increase in mortality of almost 100% in Africa. Here's a map of the world showing you the #1 cancer killer for women worldwide. What I was trying to show here is, as you can see in most countries, pink represents breast cancer. Breast cancer is the leading cause of mortality. In countries with, I guess, so-called high income or high development index countries like the US and in Europe, breast cancer has been overtaken by lung cancer, and part of that is because of the treatment availability and treatment options there are for breast cancer. In Africa, cervical cancer is still the #1 killer, but breast cancer is poised to overtake cervical cancer in the next 5 years. So just trying to impress on you the importance of breast cancer. So there is a difference in incidence rates of breast cancer in different parts of the world. The incidence rates are in fact higher in high income countries. So in this graph, this shows a variety of cancers in women. Breast cancer is not the #1, as you can imagine. You can see the difference in incidence rate in high income countries versus low income countries. But I think what's crucial here is when you look at mortality, so incidence is in blue, mortality is in red. There is in fact increase or higher mortality rate of breast cancer even in low income countries. So as you can imagine, the mortality to incidence ratio is dramatically different in high income countries versus low income countries. So bringing it down to, comparing the US and Rwanda. So the yearly mortality to incidence rate of breast cancer in the US is 14%, compared to 50% or even higher in many other parts of the world. In Rwanda, it's about 53%. We know some potential reasons for these difference. Obviously, there are different stages in presentation. So compared to the US, where 6% of cases present with metastatic disease at presentation, in Rwanda, about 35% have metastatic disease at presentation. However, that's not the entire explanation. So this is a graph that I pulled from a paper that was published from the ABCDO cohort, which is a cohort of about 2,200 women from across sub-Saharan Africa. And in this cohort, this graph I'm showing you reports 3-year overall survival. The area in blue is what was reported in this cohort for these different countries. So this was a multi-country cohort across multiple countries in sub-Saharan Africa, including Namibia, South Africa, Nigeria, and Zambia. And what I was trying to show here is there are, in fact, differences in 3-year survival across the different countries. And they also modeled to see what were some of the things that caused these differences in survival. So for example, if these things were done, how much higher could the survival potentially be? So essentially trying to get at the explanation of what some of these gaps are. And as I mentioned, obviously the difference in staging, but so the difference in staging, so for example, if there were in fact down staging, the green parts of the bar chart of the bar graphs show you how much higher survival would be. But I want to bring your attention to the red parts and the yellow parts, which are differences in access to treatment, as well as social inequity. So those parts are also a pretty significant portion of why there are these disparities in breast cancer. So a lot of people have certainly recognized this, and that's partly what has spurred this international initiative at the WHO, which is a global breast cancer initiative, bringing together people from all around the world to really come up with a plan and an agenda to help lessen or create a path towards lessening disparities in breast cancer. So this initiative has come up with these 3 pillars as the central pillars for things they think should be addressed, as well as targets for these pillars. So the first pillar is health promotion and early detection. That's rather obvious as we talked about potential for downstaging. The second pillar is timely diagnosis. So as I will show you, and as some of you might already know, even when people present early, there are lots of delays that might happen within the system such that they don't end up starting the treatment at an appropriate time. And then the third pillar is comprehensive breast cancer management. As I would also show you later on, there's certainly many aspects to the management of breast cancer. These things are complicated and need to be thought about in a very systematic way. The targets that they came up with were 60%, countries targeting getting to 60% of their cancers being early stage, treatment within 60 days, and 80% treatment completion. So I'll come back to this schematic throughout the talk. So here is the breast cancer care pathway. Going all the way from when a patient identifies a symptom, so whatever that potential breast symptom is, all the way to survivorship. There's certainly lots of different aspects to this pathway. And as I mentioned, there are a variety of different types of delays that can occur. There might be delays that might be related to the patient or whatever the social situation is, or why they're unable to present to the health facility on time. There are also referral delays where patients actually do present, but never in fact make it through all the systems, all the levels of the healthcare system. And also after patients get a diagnosis, there are challenges in completion of care. So we'll come back to this pathway later on as well. So I'll change gears a little bit to talk a little about the Center for Global Cancer Medicine, which is a center at Dana-Farber with which I'm affiliated and which I work. I'll tell you a little bit about the center. You'll learn a little bit more, or a lot more about it tomorrow. So this is just to give you some background to explain the rest of the work. So this center was established in 2012 through a global health delivery partnership that included multiple institutions in Boston, including Harvard Medical School, Brigham and Women's Hospital, which came together to support the work of Partners in Health. Partners in Health is a nonprofit that does care delivery and supports governments in a variety of aspects of healthcare in multiple low resource settings across the world. So the center came together to support the delivery of cancer care in Rwanda and in Haiti. Some bit of context about this. These cancer centers are based within government facilities. The cancer treatment services themselves are provided at no cost to the patient. In the case of Rwanda, there's also a national health insurance scheme that covers other aspects of the patient's care. And also just to mention that there are in fact other academic partners. That's the context in which I will talk about the next examples, which will be going through some contextual data that we've collected in these two countries. So first we'll talk about breast cancer outcomes in Haiti. So this is the hospital. It's quite a beautiful hospital called University Hospital Mirabelais. In 2018, we, in conjunction with the team there, decided to make a retrospective cohort of breast cancer patients, just looking back and seeing how patients who have been treated in that program had done. So the cohort was for patients who had the initial presentations between 2012 and 2016. And we were focused primarily on non-metastatic breast cancer patients because we were interested in seeing things that were associated with care completion and things of that nature. Of note, majority of the patients were actually excluded from that cohort because they had metastatic disease. So that sort of gives you a sense of the rate of metastatic disease in these settings. For our cohort, the median follow-up time was 24 months, and we looked at patient characteristics, disease characteristics, treatments received, and outcomes. And I'll go through some of these higher level summaries of some of these things. So within this cohort, the median age was 49 years old. There were a variety of diagnostic delays and challenges. So here just an example of some. So the stage distribution within this non-metastatic cohort was still heavily skewed towards advanced disease. So over 50% of people in this cohort had locally advanced disease. Of note, about 17%, we classified them as unknown because we couldn't really tell within the records what type of staging was done. Although they were treated with curative intent, we're not quite sure what the stage was. And I should also mention that looking at hormone receptor status, which is an important part of the diagnostic pathway in women with breast cancer, almost 25% of women in this cohort did not have this checked within in the course of their care. There were a variety of treatment gaps, some of these things you would anticipate and expect. So about 20% of people never ended up getting curative intent surgery, even though the intent of the treatment from the get-go was curative. The folks who got surgery, the median time to surgery was 87 days. So that's quite a lot. Looking at gaps within systemic therapy, only about 60% of folks who had locally advanced disease got any type of neoadjuvant treatment. So this is treatment that they should get prior to surgery. So certainly underutilization of neoadjuvant treatments, as well as underutilization of adjuvant treatment. For those who initiated adjuvant chemotherapy, almost half of them had quite significant delays of over 12 weeks. And we use the 12-week mark because that's sort of around, we know that the later and later you get treatment, the worse your outcome certainly is. Also looked at gaps in adjuvant endocrine therapy. So adjuvant endocrine therapy, as opposed to other parts of breast cancer treatment, is oral therapy that can be taken at home, usually relatively cheap and readily available. So 82% of patients did initiate adjuvant endocrine therapy, which is a high number, but that also means a substantial amount still did not initiate that therapy as well. And there is no radiation facility in Haiti, so none of the patients received radiation. Here's just a summary of the outcomes within the cohort. So Kaplan-Meier curves looking at the impacts of stage and survival, and looking at the impacts of ER status and survival. So none of these are unexpected. This is what you would expect in a cohort of breast cancer patients. A couple of things that I would mention is for these curves, we defined event-free survival as dying from your cancer, having a recurrence, or having progression. 2-year event-free survival was 80%, and 3-year event-free survival was 63%. So not great, but also not necessarily terrible, in the sense that when care is available, you can in fact potentially make a difference in some people's lives. So here are Cox proportional hazard ratios looking at, so the Kaplan-Meier curves were uncontrolled. These are controlling for a variety of variables. Also not unexpected that patients with locally advanced disease did worse. So the higher the hazard ratio, the worse the patients are doing. Also ER negative disease and those who were younger than 50 years old did worse than the other populations. So I'll give you another overview of also within this exact same cohort. We did a geospatial study looking at the impact of distance and time from care, and seeing how that potentially impacted presentation as well as treatment. What you're seeing on this map, so this is a map of Haiti, and essentially looking at the road networks. So thinking that, although you can see that so the thick red lines are the major roads and the small yellow lines are the minor roads. Haiti is a relatively hilly country. So for example, there are swaths of areas like this area that has virtually no roads and virtually no roads. So people live all over in Haiti. So people are coming from all over. And I'll show you how that maps onto time that it takes for patients to get to care. The green tinge of the map shows you essentially the population density. So here's the capital of Haiti, and you can see that's where you see the densest roads and the densest green. Here's where this hospital in particular is located. So not quite located in the capital, but not that far away. So here is a map of Haiti again. What do you call it? The units that you see here are what we call the section communes, and there are about 500 of them all around the country. And the different tinges going from light yellow all the way to dark brown gives you a sense of how long it takes people to come to the cancer hospital. And what I wanted to show here as a visual is virtually, more than half of the country is more than 2 hours from this hospital. And I should say, so these 2 hours was based on an estimation of the distance based on the road network. So in reality, 2 hours is probably, 2 or 3 or 4 times more than that. And the sizes of the circles that you can see show you the places where patients are coming from. So the larger the circles, the more patients are coming from those areas. So as you can imagine, the patient's distribution sort of mirrors the distribution of the population density. So for example, places around the capital, you see there's a lot of patients coming from those areas, and that's also where you sort of see the population density. So I'll give you some summaries of results we got from this. We looked to see how time was associated with whether or not patients had metastatic disease or non-metastatic disease at presentation. These were not, so these are odds ratios that were adjusted for poverty level. So poverty at the level of the section commune. So this did not involve interviews with patients. So this is not necessarily patient level income, but this is poverty at the level of the section commune. Although these were not statistically significant, you sort of get a sense that the farther away you come from, the more likely you are to have metastatic disease. So the higher the odds ratios here, the worse that sort of represents, because this is likelihood of metastatic disease. We did something similar amongst the folks who had non-metastatic disease, looking to see what things were associated with the likelihood of patients getting surgery. So in this case, the lower the odds ratio, the worse things are. So whether or not you got surgery. So compared to folks who were living within an hour of the hospital, people who were living further from the hospital were certainly less likely to receive surgery. I adjusted this for poverty as well, and also did a stratification looking at whether or not people were living in urban areas versus rural areas and the distance that they were from the hospital. And compared to folks who were living in urban areas who were within 2 hours of the hospital, those who were living in rural areas greater than 2 hours of the hospital had a lower chance of getting surgery. So just giving you a sense of what some of the burdens might be, and quantify. So that this is not necessarily rocket science that we did not know, but this is a way of actually quantifying what the potential impacts of these things are. I'll shift gears a little bit and talk about some contextual data from Rwanda. Yes.
Can I ask a question that's very interesting in geospatial data? Just help us understand, is the hospital nearby, is that the only major hospital with Dr. questions?
That's a great question. So in Haiti, there are two hospitals considered cancer centers. The Mirabele Hospital is the only one within the public supply chain. There are 4 other smaller clinics that do provide some form of cancer care. So although it's not the only place, depending on what your resources are, this might be your only option.
Okay, because it's care free, or
because the care is free.
free, okay.
Correct.
In Port-au-Prince, is there no major
So there is a major general hospital in Port-au-Prince, but they don't have a cancer facility. There is a nonprofit that runs a semi-private cancer facility in Haiti, but it's not entirely, in Port-au-Prince, but it's not entirely free.
Thanks.
So, yes.
So where do patients who have indication for radiation go?
That's a great question. So there is radiation in the Dominican Republic, which is nearby. The radiation facilities in multiple parts of the Caribbean. As opposed to the strategy that, as you know, we had when we were in Rwanda, when there was no radiation, where either partners in health or the hospital system supported patients to go. That type of support does not exist. So it's patients on their own dime. So the type of patients that end up coming here are not necessarily patients who are able to afford that.
Okay, so even though it's a cancer hospital, it's surgery and medical.
Correct. There's no radiation. So there's no radiotherapy in the country.
And what's the population?
11 million, 11, 12 million. Yeah.
So most of the patients that come to this hospital,
Mhm.
they don't get radiation.
Only a very select handful might get radiation, either through a variety of family support. There was a time when there was some funds to send a select number of patients, so like pediatric patients. But the reality now is patients have to organize themselves.
Is there efforts underway right now with the government or other organizations to develop the radiation?
Yeah, that's a tough one. It's a tough one because there are currently lots and lots of challenges, political challenges in Haiti. There has been talk and there has been plans. There was a radiation facility in the 70s, actually. So there was a radiation facility before. Yes, so there are talks, but I'm not sure.
But nothing on the short term horizon.
Nothing on the short-term horizon. Yeah. Okay. So what I've showed you before were, based on retrospective stuff that didn't involve really talking with patients. And what I'm going to show you here is results from a mixed method study that involved interviews and surveys of patients, and this is in Rwanda. So as I mentioned, we're going to come back to this. So this is the breast cancer treatment pathway that I had shown earlier. The focus of this study is looking at care continuum delays. After the patients have presented to the cancer facility, what are the challenges they face in completing their treatment? And similarly, this cohort of patients we're talking about are patients who have non-metastatic breast cancer. So there is, in fact, an endpoint to their treatment. So the point of the study was to assess barriers and facilitators of care completion. So this is a brief schema of what the study involved. Qualitative interviews of 20 patients, a quantitative survey that ended up being administered to 89 patients, and some retrospective chart abstractions in about 215 patients. I'll go through some of the results, just high-level results. So the domains that we were interested in, you can see the inclusion criteria, but the domains we were interested in were, disease, treatment and knowledge, social economic status, treatment toxicity. We specifically also asked about transportation because we wanted to delve a little bit more into that. Communication preferences and technology use. I won't talk about the results of those later portions. The reason we asked those questions were because we were trying to assess some potential interventions that we might try. I'm not going to go through this in incredible detail. All I want to mention here is, so these are results from the survey. We categorized the barriers into a variety of categories, and I just wanted to mention the high-level categories that we used. You'll have access to the slides so you can look at the details. So blue here are people who said yes to this question, red are people who said no to this question. So the barriers were categorized into, there are some challenges that are in fact inherent to the cancer treatment, which you can't really change per se because cancer treatment is challenging. So for example, it could, cancer treatment sometimes can be 6 months long. There's nothing you can really do about that. That's just inherent to cancer treatment. There were some challenges that were sort of related to family and social support. So the lack thereof, or the perception that some of those were missing. And then we have this category of challenges that were potentially amenable to health system intervention. So for example, patients identifying poor understanding of treatment, forgetting about their appointments, treatment side effects, treatment costs, and difficulty in navigating referrals. So these things we could in fact do something about. Those results have in fact been acted upon in a variety of ways. I don't have the time to go into all of those ways, but certainly provided information for potential interventions. Here are the results from the transportation challenges. So as I mentioned, I don't think I mentioned this, but here's a map of Rwanda. We also did a similar geospatial stuff in Rwanda, but I won't go into all the details of that. But all I want to show you is here's the capital, which is Kigali, and here's where the hospital is located. So similarly in Rwanda, this is not necessarily the only place where patients can get cancer treatment, but for a variety of reasons, because of the way the system is set up, this is usually the option patients have who have limited resources. So most patients were not coming in with their own cars. Most patients were coming on public transport. And the median travel time was 7 hours. So that's a lot. So thinking of patients who are sick, have just gotten chemotherapy, all of that stuff. So cost of travel was about $12 for each round trip. And many times patients are coming every 3 weeks or every couple of weeks. And that's quite a significant burden on patients. A lot of patients were getting some sort of financial assistance. And there was, in fact, already a system in place to get financial assistance from the hospital, but clearly that was not sufficient. So this has also spurred some potential reevaluation of how patients are in fact supported. I wanted to briefly mention some of the themes from the interviews. This was quite interesting because this was the first time I'd done a qualitative study that involved interviewing patients, and the interviews were conducted first, and there were a variety of things that we learned from the interviews that we would not have thought about in the way we thought about them before we asked the surveys. So there were concerns about insufficient support from the hospital, transportation challenges, like I mentioned. This study was actually done in the middle of the COVID pandemic, so that compounded all the transportation challenges as well. Fears and misconceptions around cancer, abandonment by spouses and family, as well as sometimes a sense of community isolation or challenges getting reintegrated into society. Some of these themes have spurred another project we're doing on cancer stigma, which I won't go over today, but it was quite interesting seeing and just organically getting from patients what things were in fact challenges for them. So question is, what are some interventions we can potentially do to improve care delivery and optimize available resources? So understanding that irrespective of what we do, there are always going to be limited resources. So how do we optimize the use of the resources that we have in settings like Rwanda and Haiti? Well, that's the $1 million question. So just going back to the WHO Global Breast Cancer Initiative diagram that I showed earlier, I'm thinking about the pillars and thinking about the targets. So I will talk about a couple of studies that one is completed and one is ongoing that address elements of pillar 2 and pillar 3. So the idea of having timely, accurate diagnosis, and also the idea of trying to optimize some things to help patients get better care. So here are some questions that we'll be sort of going through in the next few slides. So what's the process and cost of a breast cancer diagnosis in a place like Butaro Hospital in Rwanda? How can incorporating novel molecular diagnostics impacts this process and costs? How can we also improve the use of endocrine therapy? Endocrine therapy is really low-hanging fruit, and that's a resource that is available. So how can we sort of try to optimize that as much as possible? Similarly to the, I showed you the breast cancer care pathway. There's also a breast cancer diagnostic pathway. So this is a simplified version of that pathway. I'll show you a more complicated version in a second. So when a patient comes, so these are patients who are coming with, masses that they self-palpate as, and these are not patients who are coming with asymptomatic disease. They have a mass, they have something, they have a wound, they have some bleeding. When they come, it's not a one-day process for patients. So they come and they get seen, and then usually the biopsy is not conducted on the same day. The next day they get the biopsy. There's a process that happens in between, and day 3 could be, 2 weeks from now or 3 weeks from now when they come to get the results. And then things happen in the lab, which are, H&E diagnosis. So that's just a basic pathology. And then another important aspect, as we talked about, is the subtyping. So telling what type of breast cancer it is, because that certainly impacts treatment options. So the laboratory process can be, it can involve expensive reagents. It can be complicated to get everything in stock all the time. Also, it requires highly skilled technicians. So just, I know this is something that you all know, but just to, state it out loud, biomarker analysis in breast cancer, it's typically performed by immunohistochemistry. It certainly determines treatment. In many parts of the world, HER2-directed therapy is not always available, but certainly in places where it's available, it certainly impacts treatment. Most cancer centers in sub-Saharan Africa really don't have the capacity to do this on a consistent basis. Actually don't have the capacity at all. And then the places who do have the capacity can't do it on a consistent basis. So certainly in the case for endocrine therapy, it does impact what you can potentially do for therapy that is already available. And so there are in fact some neuromolecular technologies, and I'll give you an example of one which we're testing in Rwanda. For those of you who are familiar with the infectious disease world, Gene Expert is a platform that is widely available all around sub-Saharan Africa and in many other parts of the world. And it was a platform that was developed and implemented for TB diagnostics. So I don't know if you guys remember, back in the days, the way to get a TB diagnosis was to culture, which sometimes could take weeks upon weeks. And then it took an additional 4 weeks before you could get the resistance, whatever. So Gene Expert was what sort of totally revolutionized that, because this was a platform that was looking for nucleic acids for TB, and it could give you within 30 minutes to an hour whether or not you had a TB diagnosis and whether or not you had resistance. So we heard that the company had also developed a cartridge or an assay called the Strat4 assay, which is a novel, semi-automated assay that is able to do nucleic acid extractions, do RT-PCR, all of that within one cartridge, which gets inserted into the Gene Expert machine that is already available and can potentially actually tell you the difference between, ER positive, HER2 positive, and PR positive breast cancer. And this has been studied in controlled high-income settings in which they compared the results of the Gene Expert Strat4 assay to immunohistochemistry, and the concordance rates were incredibly high. So over 90% for ER, as well as that's comparing it to IHC, and also for HER2 comparing it to high IHC plus or minus FISH. IHC meaning immunohistochemistry, and for HER2 sometimes there are studies, they're equivocal ones where you can't really tell whether or not it's in fact HER2 positive. There's an additional study called FISH, so the combination of those compared to the STRAT4 assay has been shown to be incredibly highly concordant. This has been done in high-income settings, but hadn't necessarily been studied in a setting like Rwanda and other parts of Africa. So in collaboration with the company, we are in fact comparing immunohistochemistry to the GeneXpert assay in Rwanda, but there are also other studies going on in other parts of Africa. But what I thought was also interesting about this, the additional level that we added to this was we were trying to see not only how well can this stuff actually work within a sub-Saharan African context, but how can it in fact impact the process of care and how can it impact the potential cost. This study was done with a student who was working, doing a research fellowship, a Fogeti research fellowship with us in Rwanda for a year. And we used the methodology called time-driven activity-based costing to sort of map out the entire process of the breast cancer diagnostic pathway and look at, how the processes might change and look at the costs that were associated with each of those processes. So I wouldn't go over this in all the details. I will show you a couple of maps that might look complicated, but we're not for us to go over it, but just for you to see the extent of the process of the diagnostic pathway. So this involved, clinician interviews to make a process map, which I will show you, staff interviews, and also like finalizing that process map, shadowing patients as they went through the entire process map, as well as getting cost data. So this is just to show you the different processes that in fact go into each of those days that I showed you earlier when a patient comes. And we mapped this out for the different days in which the patients touch the healthcare system. I'll blow up the day one. And on day one, you can see that there are numerous parts of the personnel that actually touch the patient. So there's a nurse, there's a physician, there's a social worker, there's a lab technologist, there's a cashier. All of these processes also have times associated with them, which were all mapped and tracked and had costs associated with them. And that was done for the entire diagnostic pathway. So I'll just show you a big high-level summary. So all said and done, the cost of a breast cancer diagnosis at Butaro Hospital was about $138, which in the grand scheme of things is not crazy, but that was the cost of the entire pathway. Of note, 49% of that cost was from the biomarker analysis, and this was doing it using immunohistochemistry the standard way. And then we did a comparison to STRAT4, and here's a summary of that. STRAT4 did not necessarily reduce the costs dramatically. There was in fact some cost savings, but what STRAT4 did was it actually did reduce personnel time pretty significantly. And this paper is going to be published in the next couple of weeks or so in the WHO bulletin. So just giving you an example of how a novel technology can leverage something that is already existing in low resource settings to potentially make a difference. And the last thing I will tell you about, yes.
So the 130 something dollars.
Yes.
After completion of treatment, or it's just
the diagnosis. So from day 1, 2, and 3. So from the initial consultation to when the patient gets told that they have a diagnosis of breast cancer. Our goal is to do TDABC for the entire treatment pathway, but we've not done that yet. So this is just for getting a diagnosis of breast cancer.
and on average, how long does it take from day 1 to 2?
Yeah, this was done in the context of Butaro Hospital. So although we did not specifically look at how long it took time-wise, routinely within 7 to 14 days, in our context, we're able to give you a diagnosis. But that's not the case everywhere else. So 7 to 14 days is pretty good compared to many other places. Yeah. Okay, so here's a study that we are in the process of thinking through and doing. And I just also wanted to mention this as an example, another example of a potential way of a potential intervention. So as I mentioned, endocrine therapy is something that is relatively available. However, adherence to endocrine therapy can be complicated, and adherence is complicated. It's not as simple as just take your medication. There are different aspects to this. There's initiation, there's persistence. How long do you take it for? How well are you taking it on a daily basis? And unfortunately, in many contexts like ours, we actually do not really have this information. We don't know how these things are how patients are interacting with these medications. So the goal of this study is really doing a mixed methods analysis to sort of understand how a patient's taking their medications and what are some of the barriers. And this is just showing you what the schematic of the study is, which is currently ongoing. So qualitative component, as well as a quantitative survey, which would not only measure adherence implementation, but would also look at adherence persistence for patients who are eligible or should be on adjuvant endocrine therapy. So this takes me to my last couple of slides. So I just want to also mention that in a way, there really is no way to achieve this goal of the WHO if you don't focus on social determinants of health, because social determinants of health in this setting are sometimes can be potential insurmountable barriers for patients. So I don't specifically tell you how this program deals with social determinants of health, but all of that to say is, delivering care in a low resource setting like Rwanda or Haiti, you certainly really need to address this in a very systematic way, assessing what the barriers are with patients at the get-go and having a system in place to address these things. So that's just something I want to say and put out there. And here are my conclusions. Hopefully I've been able, I don't need to convince you about this, but breast cancer burden is growing and it will lead to worsening disparities if we really don't do anything about it. We're trying to do something about it. And contextual data is crucial for really understanding what the current state is, what are some of the contributors to disparities, and how to really develop interventions that would work within those specific contexts. So looking at data from other places or similar places might not necessarily always work. So you really have to figure out a way of looking at within the specific context in which you're working. Also just saying that, a multi-pronged, multi-pronged approaches are necessary to reduce disparities, and they could involve a variety of things, but thinking about appropriate ways or appropriate ways of utilizing novel technologies, ways of assessing things in a very systematic way. So we've used a lot of mixed methods stuff now within our context, because we find that not only does that help us at the beginning, it also helps us to assess after we've tried out interventions. And also the fact that proactively addressing social determinants of health is important. So lots of acknowledgements for a lot of people. So I'll leave the slide up. Certainly collaborators in the Center for Global Cancer Medicine, Partners in Health, both in Rwanda and in Haiti, my mentors and folks who have been helpful with funding as well. So thank you.
So thanks very much, Dio. That was really amazing breadth of work to tell us about in impactful work in such a short time. We have a live audience here. I'm also going to check the chat. Any questions from, Chris, go ahead.
Yeah, thanks. That was a great presentation. It's just really exciting to see the breadth of your work, especially in the mixed method space. And one thing that I've struggled with in the work I do globally, and for many people notice this as well in their own work, is this disconnect between our systems focus on new shiny technology that is very expensive with small benefits, and ignoring the fundamental elements of care that can make a big difference. And clearly in your work, you've chosen to focus on the latter.
Yeah.
And I was wondering, have you run into difficulty with policymakers or colleagues or systems where they're less interested in the really important stuff, which is what you're working on, and they just want the latest robot or monoclonal antibody?
Yeah.
And how do you reconcile that?
I think that's definitely a great question. There's always that tension of, there's something out there that is new, and how can we use that new thing in our setting, or how can we, incorporate that new thing? I think in the places where we've worked in Rwanda and in Haiti, the times when we started working there was really not a lot. So the folks there really recognized the importance of creating a good base. So both places started out, there were rarely any oncologists. So the care was being delivered by, general practitioners. So the idea that, okay, a good base needed to be set up before you sort of talked about fancy stuff has sort of been ingrained into the setup of these programs. But not to say that there are no challenges. And I'm not sure I have a good question, a good answer for policymakers who are saying, okay, let's try the new stuff, other than to tell them that look at the benefits for, like, how can you sort of you're not going to have the money is limited, time is limited. So recognizing that limitation and saying, how can we really optimize stuff that we have and we're using, rather than, focusing energies and time on fancy stuff that might not necessarily make a lot of difference.
Thanks.
Thanks.
I do have a question.
Nav,
So, thank you very much for the excellent presentation. So I'm interested to know if, because you talked about the diagnostic and the treatment thing. So, are there any public health programs for like screening, breast cancer and cervical cancer at the top most?
Yes.
It's actually a lot of mortality and morbidity. But are there any efforts from public health standpoint where there's like efforts to create awareness among people, or any screening program?
Yes, absolutely. Yeah, I talked about the diagnosis and treatment because that's what my work is focused on, but there's certainly lots of efforts on the earlier side. So for example, in Rwanda, the focus on HPV vaccination has been huge. Rwanda is like the most vaccinated country in the world when it comes to HPV, for example. There are programs to educate the community. There are programs to encourage earlier detection. The Ministry of Health has sort of been working on integrating early detection programs between breast cancer and cervical cancer. So yes, there's a lot of that going on. I'm not as closely familiar with the details of those programs, so all of those certainly exist, and all of those are like part of the grander national plan, for example, because there's a cancer control plan, and that's a part of that plan.
Nazar?
Well, thanks, that was great. I think this is what we need to be done, is to look at those pieces and bring it together. The challenges in lots of other parts of Africa would be, the fact that where you see the physician is different from where you get the ER researcher. So in most places, the patient has to come, pick up the specimen, take it to another lab, and then they may not be able to pay, or they may bring it 6 months later when they were able to pay, and there's no argument. And so, do you think there should be a focus on having public systems where these things can be, the institution itself that can provide the same service? And, I know like this technique of doing ERPR with that kind of in a public hospital. Great. How are we going to study that? I see that a lot in cartoons and all over the place. And most patients are not able to afford.
I think you're absolutely right. That in my opinion, cancer care only really works right if it's within the public supply system. And that's the only, well, in my work for like the small elite at the top in the private world, but the only way it would work for the population is if it's within the public supply system. Even in so-called wealthy countries that have money, cancer is expensive. So being able to like get through a diagnosis and treatment, and also the burden of what the cancer does to you financially, the only way, in my opinion, that it works is if it's within the public supply system. So I would certainly say, African countries, and a lot of places are already doing this. So there are places that either have laws in the book that cancer treatment is provided by the government. The places like Rwanda that might have an insurance scheme. So there are varieties of ways of getting at that, but it really needs to be championed by the government and within the public supply system, in my opinion. I'm not quite sure what else we can do if that doesn't happen.
Thanks. And I'm going to go to a question from, first of all, there's one comment here. Please thank Dio for a great talk for those of us out on the web. So thank you. And then there's another question here from Paula Nasute. Thank you so much for your great presentation. Could you please comment on how you stage patients for metastatic disease clinically, any imaging studies? Do you think this also is an area that needs further intervention? Thank you.
Yeah, absolutely. So in Haiti and in Rwanda, the hospitals that I talked about, those hospitals have diagnostic imaging capacity like an X-ray. They don't have CT scans. Those places also have diagnostic ultrasounds. So staging typically is done by, at the time, the studies that I mentioned, staging was predominantly done by chest X-rays and abdominal ultrasounds. Patients who are required for the stuff, either based on clinician suspicion or abnormal findings, were referred to go get diagnostic cross-sectional imaging, like a CT scan, for example. Neither place has a mammogram. Those places also have the capacity to do breast ultrasound. So breast-guided biopsy and things like that are possible. So as I showed you in the Haiti study, there were some patients who were not able to classify stage-wise, partly because we're not quite sure what imaging modalities or what they in fact got. So it is absolutely crucial that staging be done. So I think that's certainly a gap folks can work on as well. We did in fact have a quality improvement study at Butaro, because there was also the recognition that there were a subset of patients who had advanced disease who we thought should be getting CT scans, or were not consistently getting it. And the way we were able to improve that number was through one of the physicians doing a quality improvement study of tracking it and having an intervention to help with that.
Great, thanks. And it's a great question because it's another critical part of the diagnostic pathway, sometimes overlooked. So thank you. We're at time. If there's any last questions, either here in the hall or on the web, we can take perhaps one more question. Thank you from the question. Otherwise, I'll thank Dio for an amazing talk. Thanks for the folks who showed up here in person. Thanks for the people who showed up on the internet. And then Dio will be talking again tomorrow at Department of Oncology Grand Rounds at 8 a.m. So if you need a link for that, you can email me at scott.berry@kingstonhsc.ca if you haven't been sent it already. Otherwise, thank you. Awesome rounds. Really, really excellent. Thank you.
Thank you.